Today's program is titled Thought Leader Perspectives Webinar, Top Practice Business Issues, What Attorneys Need to Know. A special thank you to Stout's support in bringing this education to AHLA members free of charge. Before we get started with today's presentation, I would like to draw your attention to the links box located on the left of the slide. There you'll see a link labeled Course Material Website. When selected, you'll be directed back to the learning platform where you can access the presentation slides and complete the webinar evaluation. It is now my pleasure to turn it over to today's speaker, Jeff Gorke, Managing Director of Healthcare Consulting at Stout. Jeff, welcome to the program.
Thank you, Jill. I appreciate it. And good afternoon to folks on the East Coast and good morning to everyone else, I guess. I appreciate you carving out some time during the course of the day today. I have a lot of information that I want to get through, and hopefully we'll be able to get it all accomplished in the 45 to 50 minutes or so, and leave some time for questions. And if not, I'm always available to discuss some of these issues after the fact. I want to give a little brief history as an opening, kind of set the table as to my history in healthcare. I've been in healthcare for 30 years. Cut my teeth running private practices, and then moved over to the healthcare advisory side / consulting side about 11 or 12 years ago. I have a history in academic medical centers, not-for-profit health systems, critical access hospitals, skilled nursing facilities, and private practices. So sort of a wide array of things. And so I come to the presentation today to really cover some key issues that are troubling to clinics, whether they're hospital-employed models, clinically integrated networks, or private practices. Many of these issues really walk across the business practice lines, if you will, regardless of employment and structure. So we'll get into that a little bit. A little bit about Stout. We're right about 30 years old, close to 500 employees. We have an international presence, 6 offices overseas and another 22 or so in the U.S. Primary business functions are investment banking, disputes and investigations, forensic accounting, business valuation, and consulting. And in those areas, we have subsets that handle healthcare. So what I wanted to do today is really give folks an understanding of the issues that wreak havoc in medical practices. Again, whether they're employed by health systems, whether they're large private practice, small private practice, these issues are they're endemic throughout unless practices are managed appropriately. I want to contemplate components that, as you look at a practice, you get a sense of where to go, where to drill down into right out of the gate to understand some of the areas that need remedy or need to be examined in terms of financial health for the practice, and then discuss the benefits and the value of objective measurements. There's still medical practices out there that don't have a good handle on their data, and it's interesting to me that in healthcare, as important as it is, as a $3.3 trillion a year business, we still do a fairly bad job of really harvesting our data and making use of it. Getting better on the clinical side, getting better on the business side, but still we do struggle a little bit in that space. And then look at key attributes of a successful practice and what it takes to really help a practice to prosper, move ahead, and grow, especially in these trying times with additional requirements on documentation relative to some of the new payment schemes and value-based healthcare and things of that nature. And then look at the issues some issues that lead to failure of medical practices. And so if you would take a minute, I'm trying to get a sense of the audience relative to how I present this. If you would just take a second or two to click on one of the boxes that best fits you, A through G, hospital employed, private practice, or doing work with PE, or angel funded, just to get a sense of where folks are. Okay, so interestingly, or not, About 40% plus or minus folks are in, do a lot of work with health systems employing greater than 10 MDs, which is probably going to be just about all of them unless you're in a critical access hospital. So I appreciate folks chiming in on that. I wanted to start at the baseline here of the healthcare delivery ecosystem. And as we go through the topics, or the underlying problem areas, really I've identified 4, but they're interwoven. And when you see them, there's a fair chance that you'll look at some of them and say, yeah, I kind of get that. That's a no-brainer. But my hope for today is that we drill down into some of those, into areas that you'll be able to call a nugget out of the presentation or two to really understand more granularly where issues arise and how to address those or look at those with your clients. You know, we could talk about infrastructure and things of that nature, and you say, yeah, I know they don't have good management leadership, but there's more to it than that, and I really want to get down to some of the nuts and bolts. So when I contemplate, and I'm a visual guy, you're going to see some math today, very simple numbers to help me get my point across. So I throw this graphic out here on slide 5 to really give you a sense of what the practice visit looks like. And it's no different, generally speaking, than your visit to your healthcare provider on an annual basis, whatever the case may be. You'll go through sort of this ecosystem in the delivery of care. And anywhere on this system, something can break and wreak havoc. And usually that's either added expense to the practice or the hospital, or it's reduced revenue. And obviously, ultimately, what we're trying to do is maximize profitability and offer high-quality care. And to maximize the profitability piece, which is in kind of my bailiwick as an operator, it's how do you manage expenses appropriately and help grow revenue. And so as we move forward in discussion today, this ecosystem really kind of paints the picture of things that are involved in delivery of care on any given patient visit, whether you're in large ambulatory clinic owned by a health system or a large private practice, small private practice, these pieces all need to be touched at some point in the delivery of care. So when I noodled this relative to problem areas, I came out with these 4 key components. And like I said earlier, you're going to look at some of these and say, yeah, I get it, that's a no-brainer. But when we get into the details of why they happen, hopefully that's going to be of a lot more value to you. And these, when you think of these 4 topics apropos of the ecosystem, you come to realize that a lot of them are interrelated. And for instance, physician comp has a lot to do with productivity and or quality and or patient volume and or schedule, those types of things. And those are all impacted by the functionality of the medical practice itself, the ecosystem itself. So another quick poll here, if you would, just to get a sense of an area. If you had to pick, is there an area that you're more inclined to do work with or on? Okay, so generally speaking, the majority of you folks are doing a little bit of everything. So that's good to know. Okay, terrific. So I'm going to start with operations, what I'd call disaggregation. It's really maybe multiple parts on that ecosystem going in a chaotic way all over the place, not staying focused, no kind of rhyme or reason. A lot of times what happens is, and if you look at this relative to any private practices you deal with, and even in health systems, there tends to be a growth of management internally, which makes sense sometimes, and sometimes it doesn't. And oftentimes, especially in private practice, where it's cash accounting and $1 in revenue, if I don't spend that $1, I obviously have $1 to drop to the bottom line. So many times we, on the operations side, underinvest in management, which ultimately can cost you multiple times over for a variety of reasons, whether it's in compliance or billing or collections, all that stuff. So and from an operational perspective, if you look at that ecosystem or contemplate that relative to a pyramid, you know, operational structure is key towards the sound foundation of moving that pyramid forward. So to use a trite aphorism, there you go. So think of a pyramid. New delivery of care in terms of the operations. the new paradigms, macro-MIPS, ACOs, all those good things that are forcing physicians now to deliver care, not in a different clinical way necessarily, but really optimize how they do it, and there's a lot more data reporting and things of that nature. So it just made things more complicated, and I would suggest to you they're more complicated for health systems just like they are for private medical practices. It's just that in the private practice setting, the clinic eats the pain more readily on the front end than necessarily the physicians who are in employed models, because a lot of the pain and suffering starts at the healthcare IT, CMIO space, and then it gets pushed down to the docs. But lower cost, high quality outpatient care expectations. As you all know, the carriers, the payers, Medicare, Medicaid, and the commercials are looking for low cost delivery, quantifiable quality results such as those are, and repeatable quality. And anyone who's been in the clinical space knows that that's a little bit of a challenge on its face, especially the definition of some of these quality measures. But the goal obviously is to reduce cost and improve quality of care. And in the meantime, reduce length of stay in the health system, reduce readmits into the hospitals, which is going to hurt from a financial perspective the health systems. And those patients are going to be managed externally, either in ambulatory outpatient or in many cases telehealth, telemedicine, which is on its way a little more aggressively. And then on the operations side too, and many of you know this just based on your business, staffing is the largest cost in a medical practice, running roughly 25 to 35% of collected revenue. And so obviously, high turnover rate is problematic because you have training, you lose institutional knowledge, and then you're paying folks and retraining them. So investing in good quality clinicians and business folks makes all the sense in the world. But again, if you're looking at the spend on that as one of the biggest cost components on the P&L, makes some folks a little bit itchy, if you will. So some of these component pieces, the management lacks credentials and experience. What I mentioned a little bit earlier, you'll get someone maybe who grew up with the practice and has been there forever and maybe hasn't kept their skill set up, or the job just got way too big. So they started in a practice 30 years ago with Dr. Jones, and it was just the two of them, and now Dr. Jones has 50 associates, and you still have that person, kind of manning the ship. If they haven't kept up with their credentials and really the operational delivery of healthcare, that becomes a problem. And then you look at staffing as too many or too few. Do we have 10 MAs running around to help Dr. X out? You can make an argument he doesn't need 10. Do we have too few? Is he being really cost conscious and we have one MA for one physician, or one MA for 4 physicians, or an MA who does everything in the office? Again, you can make the argument that you're really cutting off your nose to spite your face. Then it becomes an issue of right person, right job. I would argue that you don't need an RN for every physician in a practice, that you should use RNs to the fullest scope of their care to help deliver care, but maybe it makes sense to have 2 MAs to help a physician. So again, that becomes a cost and a care delivery proposition. And then using clinical staff, say RNs, nurse practitioners, physician assistants, to the full scope of their practice. Now, depending on what the doctors are doing, does that mean using them standalone, using them billing incident to? But the last thing you want to do is just have them be a crutch for the physician to help him or her get more patients through the door. And then you think of span of control. Do I have one person managing one person, or one person managing 10 or 20 people? And again, there's too few or too many. Those structural questions really come into play when you're building that base of the pyramid. Candidly, one of the biggest things, and this may apply to most businesses outside of healthcare because it's a business issue, is policies and procedures. We've got clinical protocols that we have to manage, hopefully, and we're doing all we need to on that end. But then do we have cogent policies and procedures on how we see a patient, how we drop a bill, how we follow up on a bill, personnel policies and HR on those related things? That all goes into operational soundness and structure. Then you think about healthcare being practice management essentially, but then healthcare adds the twist of FMV, Stark, anti-kickback, and then you have your HIPAA thing. So there's there's that added piece of peculiarity to the model. And then really understanding the complete and detailed P&L. Physicians in the employed space, a lot of them got acquired. They come from a cash accounting perspective where $1 in the door is $1 to spend or save or whatever. And they get immersed into an accrual accounting process, which they don't understand. And then generally speaking, they come in and they get told that they're costing the health system money when the health systems a lot of times have pulled out ancillary and diagnostic stuff into the system, and the physicians are just seeing patients. So understanding that P&L, helping the practitioners to understand and managing the revenue expense side. And I mentioned clinical protocols in that, you know, truly having protocols in place to manage whether it's pre-visit, visit, post-visit in terms of follow-up care. So ensuring that there are the appropriate waivers and disclosures if you're going to do a cath on somebody, and help them understand what that risk and exposure is to them, and then closing the loop. Let's say you've done a diagnostic study, you get the results back, and then you need to ensure there's a closure of reporting the results or getting the patient in if the results fall outside the protocol, et cetera, et cetera. So med-mal mitigation, deploying good protocols, and then provider expectations. I've dealt with many practices, hospital models where there's this disassociation between the physicians and the C-suite, and really the physicians just want to be heard. So you right off the bat, you start with some political upheaval and things of that nature. Using the physicians, managing their expectations, and their delivery expectations, clinic expectations, all those good things. I dealt with a academic medical center where the university would bring on physicians, and then the faculty practice would just get a memo saying Dr. X is going to start on whatever day, and not know what the expectation was for the physician, what his or her start time was. So you can see where a little hard for the clinic to manage staffing, to manage patient volumes, et cetera, et cetera. So on that ecosystem, sort of pulling this all around back together, you can see patient eligibility, scheduling, charges, receipts, fee schedules, charge capture, all of these little sub-pieces that go on a granular level underneath kind of the bigger mission. I still have run into practices who have no idea where their fee schedules are. So they don't know if they're getting paid the right amount from Blue Cross Blue Shield, or even Medicare for that matter, even though Medicare is publicly available knowledge. Provider compensation and productivity, we'll get a little more into the weeds on that as we go forward. And then AR and rev cycle, we'll touch on those as well. So I mentioned earlier, big fan of sort of graphics and simple numbers because it helps me a tremendous amount. But if you look at this as a private medical practice, cash accounting, right? So revenue is recognized as dollars they collect in the door. So if you look on column, on the left-hand column, 2018, and the right-hand column, 2019, made some minor changes to this very simple, overly simplified P&L. And you see that from 18 to 19, they're down 10% in their revenue, so 10% collected money. Their expenses went up 10%, you know, nominal creep here and there. Equipment went from $10 to $11, et cetera, et cetera. The net is they went from, with a 10% drop in revenue, 10% increase in expenses, they cut the profitability almost 50%. So in this instance, you've got profit of 38 in 2018, two partners, that's a $19 share. They've now gone from $38 to split to $22, which is $11. So again, that's almost a 50% cut in distributed dollars. And also in the meantime, even if you look at 2018, the $62 represents a 62% overhead, which is really not great. So if you're looking at that, you look at, okay, 62%, all things being equal, we need to make some changes either on volumes of patients or on the revenue or on the expense side of things to open up that profitability gap a little bit. So that is that. And then the health system, I just threw this in as an accrual accounting, right? So the gross revenue is recognized dollars out the door that they accrue. The contractual amount is what they expect to reduce that gross revenue amount by, and their net revenue obviously is exemplified there. So it's the same kind of thing, except when you get down to the bottom, you see profit loss going from $27 loss to $42 loss. And for those of you, I mean, most of you are in the hospital side of things, so that's what the hospitals refer to as a subsidy. Obviously, they are subsidizing in 2018 to the tune of $27. So you can make an argument that there's some sort of value in other areas that would offset that $27. But in any event, this is just a real simplistic measure of, or look at the differences that small changes can make throughout the P&L. And one of the things I'm a big fan on, and don't get lost in the numbers, or you can later after this if you'd like, you can measure any number of things in a medical practice, but you have to identify those things that are going to bring the most value. And so if you're doing a meeting, you're having a meeting with a private practice with their board, or even the health system board, there's got to be metrics and then measurements, KPIs, that are in place to show what we're doing. This is a real simple thing that I put in front of you. It's a 3-doctor practice. They look at their monthly numbers, which net don't have a ton of value because there's a lot of variability from one month to the next. But they also do a year-to-date measure in this example. And so they're looking at their revenue for all 3 doctors, they're looking at the expenses for the practice, and they're measuring their overhead. And then these guys really want to increase business, so they're looking at all their new patient visits and the changes in those. And then, by the way, Dr. 3 does surgeries. They're measuring his output in surgeries, and then RVUs. So these are things that this practice in particular, our fictional practice, has decided they want to measure to show growth, to show profitability, et cetera, et cetera. So my argument is whatever it is, measure and monitor so that you can know ahead of time, or at least react very quickly when things are getting sideways. So kind of in summary of the operational piece of things, complete and detailed P&L review, analyze all of those pieces. The health systems need to have good, solid management in place to manage all of those component parts. And, you know, like any good leader, any business, anywhere, you surround yourself with the best people. Don't think you're the smartest one in the room. Get out there and engage folks to make decisions. Don't dictate, because I still see a lot of that in the healthcare space. Compensation versus production, and we'll talk in more detail later. Obviously, in this model, unfortunately, the widget makers are the providers, and they're the ones driving the revenue bus, if you will. And so an operations reviewer, understanding granularly all of those line items in a P&L, helps you to address the broken pieces. And there's plenty of benchmarking out there to be done to really analyze what's broken and why. And you know, there may be reasons certain things are broken. It may be a you know, healthcare is local, and there may be a geographic reason as to why you have to spend X more dollars on something in particular in Albuquerque than there is in the greater Atlanta area. So those kind of pieces need to be taken into consideration when you're reviewing P&L. So provider compensation. Again, probably a no-brainer, but I wanted to walk through some of the different reasons why it can be a hobgoblin into the efficient operations within a practice. So incongruency between provider comp and production, lack of alignment between comp and collections, and comp and productivity. So are we paying Dr. X guaranteed $250,000 a year, and we're only collecting $80,000 a year off him? We might be in FMV compliance on the comp, but we've obviously either got a billing issue or he's not seeing enough patients. And then that gets to comp and productivity. So are we paying him? Is he generating, seeing enough patients, et cetera? Equal shares models don't equal work necessarily. Misaligned incentives, schedule optimization, and then extenders. And so the evolution, and many of you probably already know this, but the general, if you will, evolution of the provider comp models have been, you know, acquisition by health systems of providers in the 90s with an eye towards managed care and how to manage those lives under one umbrella. A lot of income guarantees were issued, and in many instances, health systems got upside down and divested. In the 2000s, that model became a little more, I'm going to say thoughtful, but I'm going to say thoughtful. incorporating some work measures to provide incentives to physicians to see patients, and those involve the wRVUs, which obviously are a construct of Dr. Shao out of Harvard and Medicare, and are kind of the most consistent measurement of quote-unquote work that we have in the industry, so obviously acceptable or accepted for that reason. And nowadays, kind of fast forward or get beyond 2010, you're looking at RVU comp models, maybe with some base, maybe with some other outside inputs like efficiency optimization, care management, things of that nature. So we look at the salary guarantees, again, a little graphic to really give you an indication as to why things went south, broadly speaking. Guarantee Dr. Jones $500,000, he produces $350,000, again, whether he produced that or we collected that, and we're upside down $150,000 on him. So when you look at the 2000s RVU model, and I built some of these back in the day. So this is not to say one size fits all, obviously. You've now got your co-management agreements, you got your PSAs, which are fairly dynamic, you've got JVs and things like that. So, but this is just to give you a sense very simplistically to cover a broad swath of these models. So Dr. Jones, 8,000 RVUs at $25 per, and he gets $200,000. And so there weren't a lot of historically non-comp related incentives, so not a lot of quality related necessarily. Not a lot of efficiency necessarily. And so you move on to sort of an updated version of this, and you've got Dr. Jones, 8,000 RVUs, $25, but then we throw in other measures, and I'll put a little example together for that later. But then his comp ends up being $250,000 a year. Again, obviously, has to pass fair market value on the net debt, but we've built this out and we said, yeah, we need you to do these other things in addition to see patients. So sort of a citizenship thing, if you will, which encompasses a lot of different things. Newer models have some non-production components, measures, and incentives, such as quality and efficiency. And so some of the other pieces, mention quality, expense control. Are we managing where we can, right? There's got to be some way the physician can impact the expense side. You can't just hold his feet or her feet to the fire without giving them something measurable and that they can impact. Coding and compliance, good citizenship, and Medicare obviously is now looking at patient SAT scores as a reimbursement tool in the greater scheme of the macro MIPS equation. You may pay some more for call coverage and things of that nature. So these things aren't one-dimensional, obviously, and I'm sure many of you on the phone have seen these in different iterations and forms and have maybe designed some yourselves. But this is just to give you a sense of those types of pieces in the history of what has transpired. So if you look at it this way, kind of, again, boiling it down into a real simple model, you've got an employed physician, revenue of $100 in the system. They have expenses generally of $50. And so we look going left to right. I pay Dr. Jones $2.50 for 10 wRVUs. He gets $25. He's got 2 disease states that he manages, and those have measurable criteria that we've all agreed upon and medical staff need to be handled to keep patients dry if they've got CHF, et cetera, et cetera. So he does that. We're obviously giving him $5. Well, I don't know. Maybe it's not obvious. Maybe he gets $7.50 and $2.50 for those. So he's going to get $10 out of that, and then his efficiency practice costs reduced by 5%. We gave him some goals. We looked at some things he can do, maybe move some staff around. We don't need the 10 RNs. We saved $80,000 in salary by not deploying an RN when we could have deployed an MA, maybe 2 MAs, and increased his productivity. So net, you add those components and see that his comp is $40, the 25, the 10, and the 5. And so when you reduce that or you remove that from the other revenue stream, you can see that the hospital's bottom line is $10. And I think that akin to my discussion on just measuring things is comparatives that you might look at relative to physician productivity. So here I've got Dr. X and Y, and you can look at this a little bit later if you'd like to, but it's just simple things, right? Here's what we've agreed upon as a medical staff, or we've got a physician action committee, and we are aggressive and we want this to happen. So we've got a new patient benchmark of 5. You can see both, one physician, Dr. Y, is over by 1, Dr. X is under by 4. So that's an issue. What are we doing to address that? What's the feedback loop that gets that up to snuff? You can see also that Dr. X's revenue is $80. He should be doing $300. They're both upside down. Why is that, right? So this gives us a measurement tool that we can go back and at least start flipping over rocks. Are we not giving them the resources, or are they just not doing what they need to do? And then the overhead percent, you can see we're shooting for 50% overhead. So generally speaking, that's 50 cents in expenses on every dollar of revenue. And they're both right about where we want them to be. The subsidy, we're subsidizing Dr. X $145. The bench should be $175. So we're a little upside down on him. And then we look at his staffing. So again, this is really a facile look at some measurement tools. They can be whatever you need them to be, obviously, to drive revenue, or excuse me, anything you need them to be to drive the I guess forward motion of the entity, whether it's increased revenue, reduced expenses, or both. So in equal shares, and I did run a practice 1,000 years ago where they did equal shares, and they all made pretty decent money. But you can see here from this real simple example, this 3-doc practice, they generate $1.1 million. Dr. 1 generated $250. We agreed we're going to pay him $366. He's upside down $116. So Dr. 2 is really supplementing the incomes of Doctors 1 and 3. And at some point, I mean, they all may be happy with this, but at some point, I got to think Dr. 2 is going to make some waves and wonder, why is he working so hard to supplement the other 2 physicians? So the model can work, and all models have some degree of heartburn built into them. But this one, you can see it's really baked in and it's right in front of you. And then misaligned collections and compensation, another simple model. This doctor, here are 5 CPT codes and their associated RVUs working left to right. So he does one of each of those for 10.3 work RVUs. And his allowed amount and collected amount, right, because you don't get what you charge. So we're just going to say these are his allowances and his collections. He collects $17 on those RVUs. Okay, so we're paying him $10 per work RVU. That falls in the FMV. We've paid him $103. We've collected $17. We've got some really big issues. And that may mean we're not collecting the money. He is charging, I don't know from these data, if he's doing all the work he should be doing. Are contracts bad? Am I getting under Medicare in every one of my contracts? Maybe I need to revisit that. So again, this points you to some things, but hopefully before we get into a contract with a physician, we understand very clearly how robust our collections are, which brings us to revenue cycle. Again, revisiting the ecosystem, and in the revenue cycle touches every piece here, and this is why I want to throw it back in there. I mean, patient eligibility is the front end of the whole thing, and if I've got someone who has Blue Cross Blue Shield and they've switched to, I don't know, Medicare, or if they've switched to Cigna, and I don't know that, and I don't check their eligibility, they're going to come in, I'm going to say, oh, you still have Cigna? And they're going to say, yeah, sure, and then we're going to bill it, it's going to bounce, I'm going to have to rebill, all those things. So there's a lot of front-end stuff that really is built into the revenue cycle life cycle, if you will. And then it involves proper and accurate coding documentation, the proper dropping of the charges, you know, all the SED codes that go with, picking the right CPT, getting those out the door, and then, you know, making sure they're scrubbed for denial. So it's working all of those pieces that have to do with revenue throughout the system. So hopefully this paints that picture fairly clearly, that it's not just, rev cycle is not just, I saw a patient, I dropped the bill, I got paid, I'm good to go. There's multiple different component pieces in there. On the revenue cycle side of things, I had a client not too long ago. They had $6 million, not a ton of money, but for a small private practice, seemed like a lot of money, $6 million in their accounts receivable. And the doctor's wife said to me, well, we need to collect that $6 million. And as you all know, charges don't equal revenue. A physician can charge $1 billion for an office visit. If Blue Cross Blue Shield tells him or her they're going to pay him $100 for that, and that's the agreed upon rate, you're going to write off $9 billion, $900, et cetera, et cetera, et cetera. So unless the revenue cycle, unless the accounts receivable are net collectible monies, generally they're not. Generally they sit there as gross charges. Let's say this group has a collection rate of 92%. So if I've got $350 in AR, my possible best scenario collectible is about 92%. And so the practice I told you about in question also had a surgery center. And they had several $1 million outstanding, a lot of reasons for that. But when I went back and looked at their gross collection rate, right, so what they're going to collect generally speaking on their charges, they're collecting 10%. So, and that's over the course of 3 years. So that's a fairly rigid number that you can work with to get an understanding of what's going on within the revenue cycle. But the point being, the dollars on the books are never the issue. They become an issue, but they're never going to give you an indicative number as to what is available to be collected. So folks that talk about a great big AR and we need to get that money in, obviously it never amounts to that. And the longer it sits out there, the less likely you are to be able to collect those dollars. So, and in this day and age, with a high deductible, high copay, et cetera, front end being loaded on the patients, there's a lot more that comes into play and a lot greater need in policies, procedures on the rev cycle piece of things. So, define measurements, net charges, net collections. The net collection rate you can come up with, the benchmark really is about 95 to 100% of collectible money. So if you look at my example here, and I'm going to move a little faster because I'm eating up time and I apologize for that. If I look at my example here, I charge $100. Blue Cross Blue Shield says they're only going to pay me $80. So I have an allowable of $80. I can collect that from them and or the patient. Generally speaking, I'll collect between $75.20 or $80, depends on how good things are going for me. Point of service collection is very important. We talked about that with eligibility, et cetera, days in AR, that's how long the money is sitting out there. And again, the longer it sits out there, the less likelihood you have of collecting. Days outstanding, again, you have your buckets, and I'll give you an example of that a little later, so I won't belabor that right now. And then back-end collections, cost to collect. Are we spending more than 5% of our revenue trying to collect money? If we are, we need to look at that. So data measurement, charge captured to ensure the physicians have documented, captured all the work performed. Lag days reduced. I had a not very large client. I had a client, about 350 physicians, and they had really great numbers. And here's another reason why the numbers could be a little interesting. They had great numbers, which didn't add up because they didn't have good revenue. So when you go in and you look, what you come to find out is their great numbers were made great by the fact that physicians, the accounts receivable, the days aging didn't start until they dropped the charge. And so you have physicians with charges that were 35, 40 days before they billed them. So they didn't start to age the claim until the charges were dropped. So arguably, if you saw the patient January 1st and you didn't drop the charges till February 28th, they would age those out beginning March 1st, when in reality you've got 60 days of lag. So anyway, just another measure or another indicator as to why the numbers sometimes don't add up, and it's worth getting in and flipping over the rocks. Move on. Here's just a really, again, simple example of what it means to be aggressive on the front end collection. This is just a front end piece. So you've got a system with 9 clinics. They've got 40 patients a day, which is not good unless they've got one physician. So you're looking at 360 patients a day, average copay $30. I would argue most patients are going to have a $30 to $100, $40, $50, $100, $150 upfront payment. So these numbers are way conservative. So revenue to day, $10,000, working days a year, 253. You're looking at copay revenue of $2.7 million. So obviously it makes sense to be real vigilant on the front end and ensure you have processes in place. The client I referred to that had the 350 physicians, they had no collection expectation on the front end. So we went in and built out some expectations, looked at a budget, and within 6 months they had 7 figures of front-end collections. It's just a matter of managing it, building a process, and holding people's feet to the fire. So what I alluded to earlier, simple dashboard, and you can share this with some finance committee or with the board if it's a practice, what have you, but just an indicator of what's our goal and where are we, and what does this mean? And it doesn't get you lost in the weeds. You explain where the numbers and the KPIs come from to the physician leadership, and then you start digging into it with them at this level. So if there's an anomaly, it can be presented very clearly in red. Oh, here's where we are, not where we want to be, or we're under benchmark, so it's good, but it's not good for us. And then you go out and come back with a solution and address the physicians with that. So in summary on the rev cycle side, you need process and procedures, as I alluded to. You need those throughout the thing, regardless of rev cycle or the practice operations on the whole. Deploy defined measures, net charges, benchmark those, net collection rate, what those should be, days in each bucket so you understand what's sitting out there. Ideally, you break that down by payer, cost to collect, back-end collections, if any. Do we use an outsourced company to go after patients, et cetera, et cetera. And then, obviously, the difficult conversation is we're a healthcare provider. It feels messy for me to go out and chase patients down for money. And I get that argument. That's one of the hobgoblins of what we do in the delivery of care and the fact that it involves dollars and cents. So physicians and clinicians have to decide their comfort level with that. The last bit here is coding and compliance. Generally, you'll see this kind of sort of as a Gaussian distribution unless you're a normal curve, unless you're in a specialty, in which case you can argue that more so you'd see a lot of 4s and 5s, if you will. Coding, obviously, can be a third rail type of endeavor. And we'll talk a little bit about those pieces. Key to revenue generation, generally speaking, right? If you key all level 1s to avoid Medicare looking at you, which theoretically they can say you're undercoding and you're running afoul of Medicare. They usually don't do that, as far as I know. In my 30 years, I've never seen that. But you code a lot of 99201s when you should be coding 04s and 05s. You've obviously left revenue on the table. The coding drives the comp, right? It drives the wRVU value attached to the CPT code build. So you can see here, I dropped in a graphic on the right-hand side. These are actual national wRVUs for Medicare for 2019. So this is theoretically the work involved, and you can see it grows as the level of complexity from an 01 to an 05 grows. So if I'm doing all level 5s, I'm getting 3.17 wRVU credit times X. So you can see where that becomes a bit of a sticky wicket potentially. Technicalities and danger relative to this, you all know that piece of it. Coding and documentation providers should be reviewed in some manner with some level of frequency. I had a client once who had physicians in a specialty who had a really robust wRVU straight production comp plan. They were doing great, making good money, in the lab a lot, this type of thing. And they always passed their documentation reviews, right? So if I build 1,000 level 4s, the reviewer would go in and go, yeah, you documented for a level 4, good to go. The flip side to that, though, is if you peel back the onion, start to look at the clinic time and the lab time and the vacation time, and then you say, well, wait a minute, could you really do 90 new patient visits in an hour? That doesn't make sense to me. So there is some, passing a documentation review doesn't necessarily answer all the questions. Let's see. Distribution of codes may lead to certain conclusions, and I'll point that out in a little with some mathematics. Programs should be managed and reported on regularly, which you're talking about. So educate, monitor, manage, and repeat. There needs to be a process in place, whether it's an internal reviewer or an external reviewer, to be able to look at what's going on, educate the physicians or other clinicians on how they're coding and review. And then if you've got someone who's an outlier, maybe put them on a more rigorous schedule to get them back into your internal compliance. So here we're looking at a normal distribution. This doctor does 9 procedures, right? A 1, 2, 3, 2, 1. So it's a normal bell curve. And they get paid, they have an allowable of $10 per. So you can see they generated $270, cut and dry. Well, what if the same provider was like, you know what, I like level 4s and 5s, and here's what happens. So what I've done is same codes, same allowable, but I've changed my distribution. Same 9 patients, but now I'm up to $410 in revenue. So what that means is, theoretically, unless I can justify that with good documentation or I have a really, really sick population, I'm $140 overbilled, which begins to smell kind of bad. Not to say it is. Maybe this is the right coding for this doctor, but certainly possibly an outlier that needs a little more detailed review. And so when you take this a step further and you look at the coding and documentation apropos of a comp plan, same thing. I've used level 1 through level 5. I've used the actual wRVUs. And then I said, all right, here's production. I did 90 visits. I get paid $10 an RVU. I get paid $1,463. But then if I'm looking at doing 3s, 4s, and 5s, I'm getting paid for the same same CPTs, same work wRVU, I'm getting paid $2,000. So the message there is, okay, yeah, that's right, but you can see how the incentives can get a little squirrely, and I'm not saying physicians are billing inappropriately to generate more money. That's not my point. But my point is the coding and compliance gens and ties in with in all these count models that are built off of production. So it's just something to be aware of. And so when you look at this, I bring up this simplistic model again, where you look at $100 coming in the door, whether that's collected revenue on a hospital side and accrual, or if it's cash money coming in on a private practice. Here's all my expenses, and I've got a 50% overhead. I generate $50 in profit. And maybe that's based on me doing all those 3, 4s, and 5s. So now when I go to the P&L and I get adjusted, and this isn't even a payback to Medicare or anything like this, I'm just saying, holy cow, look what this did when he billed what he should have billed. We're down to 29% profitability. My expenses stayed the same, but my revenue dropped because this production didn't pass muster. So you can see how this, especially in a kind of a PE setting, when you're going in and doing due diligence on a practice for acquisition, is what do the dollars really look like? What's the EBITDA really look like when you go in and review the coding and things of that nature? So in summary, on the coding compliance side, educate the providers and staff, make sure there's a rigorous internal process in place or external process if it needs to be arm's length. Compare all providers to their specialty peers, just so you have sort of an apples to apples thing. If there's anomalies, make sure you understand why that is. I did Medicare fraud and abuse in the early 90s for a Part B carrier, and the outliers will stick out to them. We'll leave well enough alone on that. And ongoing education remediation to help them to understand what's going on and to keep them in compliance. Arguably, physicians don't live and breathe to code. It's not the most fun part of their day, as you may know. So just make this as easy on them as possible, but make sure they understand clearly what the risks are. And I spoke about this earlier. Don't solely rely on the coding review. Are there enough hours in the day to see 90 new patients? And I put this out there, so I'm kind of tying things up, but hopefully, again, in summary, you're getting a sense of, some of these topics may be very facile, and you may have I get that, thanks for wasting my time, but hopefully I've drilled down enough into the detail on a granular level so you can understand why those issues are problems, right? The comp thing, if you're looking at it generally and say, well, we're overpaying our docs. Well, okay, they're FMV. I'm overpaying them because they're not producing what have you. So what else is going on that they're theoretically overcompensated? What are the broken pieces that will drive to that? Same thing with revenue cycle. I mean, you're talking about these things that are interwoven, interrelated, that lay on top of that ecosystem that interact together. And when one of them breaks, it makes hiccups throughout the system, right? So the ecosystem as a life cycle, you figure out what's broken, you adjust it, you test it, you implement it, and you re-review. So in any event, I was going to tack a case study onto this, so I just kind of plunked this in here to see if anyone was interested in a case study. Obviously, we're not going to have time to get to that. I'm really kind of delighted I knocked this out in 50 minutes because I thought I was going to go way long. I'm pretty passionate about this work, and I enjoy it. So I can be rather garrulous from time to time. So I guess I can turn it over to Jill to see if we've got any questions.
Sure, Jeff. Yep. So ladies and gentlemen, if you have a question for Jeff, feel free to submit them now in our chat box located in the bottom left-hand corner of the webinar platform screen. Once you submit your question, just click send, and we will see them as only presenters. We have a few questions we can go ahead and kick off our Q&A with that have already been submitted. First question for you, Jeff. Do you think the acquisition of practices by hospitals will continue?
I think that is a little bit of a mixed bag. I think there may be some geographic and competitive components that come into play on that. That is, geographically, you may be in a small town or city out west and you feel like you need to acquire doctors and own them and employ them. You may be in a competitive situation where you just clinically align with the physician. So you may have some employed. Historically, maybe that's been the path, and you decided you don't want to take on that burden, and maybe now you just integrate with external sources. They're in your ACO. You can manage care better with them. So I think in some markets, so I guess there's no kind of magic bullet. I think in some markets, and depending on the competitive nature of the market and the business, it will make some sense. I think in other markets, candidly, I think a lot of physicians would love to be in private practice again, but don't love the idea of the headache. And so I wouldn't be surprised to see some employment agreements run their course, that some spin off and create clinically integrated networks. That way they're their own bosses. They can negotiate contract rates better. They have a little bit of leverage. They probably have a bigger geographic footprint. And candidly, if they get big enough, they can then work with the health systems from a levered position. So you may see those types of things evolving.
Okay, great. Well, we definitely have questions piling in here. A question that came in: where do you find the normal distribution for classes of CPT codes?
So it depends on specialty. I am not an expert coder. I know enough to be dangerous, and I have expert coders who do the work on that. But it really depends. So back in the day, I ran a cardiology group, and obviously higher acuity patients require a lot more time. So we had a fair amount of 4s and 5s, legitimate 4s and 5s that under any coding review and relative to peer groups would stand up to any sort of scrutiny, and that just was what it was. I think the thing where you get into some issues is when you rely on the EMR and you've clicked all the boxes, and the EMR says, hey, you could do a level 4. And I clicked a lot of boxes, but maybe it's not worthy of a level 4. And so it really depends on acuity of patients and specialty, to tell you the truth.
Another question: when you create your revenue models, do you insert an assumption for a certain percentage that will be contested or not collected from certain payers?
Oh, that's an interesting question. So if we're talking sort of a de facto, like an organic creation, and it's like square one, I would build it out very conservatively. I hate to err on the side of hyper-aggressive because it makes everyone look bad and it makes people angry. So I would go very conservatively. If I was doing a ground up, I would work on contracts with the payers and understand what I'm going to get for certain procedures. The interesting thing, and this is quasi-tangential, is that, like I said earlier, a lot of practices have no idea. And I had a meeting with a 200-doc group about 2 weeks ago to do some analytics, and even they said, we really want to understand that when we get paid from, private insurance company X, that we're getting what we should be under contract. And I said, okay, well, do you have that loaded in your system and we can just run the mathematics? Well, we don't, and I'm not sure where that lives. Well, that's not a good business model. And so I think that understanding the patient population, especially with regard to the specialty, helps you create a more legitimate financial model. So if I've got a lot of cardiology or a lot of ortho, and I'm in Florida, I'm probably going to have a fair chunk of Medicare patients, in which case I can look at some of the statistics historically and understand how to build out my revenue model. But the short answer, the short answer is I don't make a plus or minus allowance on that necessarily. Everyone should understand coming out of the gate, here are the assumptions. Let's talk through them. If you agree with them, then let's live with this budget. If you don't, then let's reduce it with some logic, and let's memorialize that so no one comes back later and says, hey, you said it was going to be $1 billion and it was $50. That's bad. So hopefully that answered the question. Great.
So we do have one other question. I know we have about 4 minutes left till we have to end. The question is, are you able to provide us your case study?
Yeah, yes, absolutely. I'll we'll get that out. Well, if you would just aggregate some names, I guess, Jill, that would be on y'all to, and yeah, I would send that out. Fine, that'd be great. Sure.
Okay, great. Yeah, we'll try to follow up with everyone after the program once we do get that from you.
But I'll give you a sense if we have a second. What that entailed was a healthcare system out west, and they had done what many healthcare systems do. They got into the acquisition mode with no real strategy, rhyme, or reason. It was sort of like, we have to do this. And they looked at the marketplace and said, everyone's doing it, we should do it, kind of thing. And I know I'm minimizing the thought that went into it, but you'll understand as I go on to this. So they ended up acquiring practices, and as many health systems do, not all of them, but many do, Dr. X had been with Susie Q for 50 years, and she needed to come on board even though she didn't return a lot of value to the organization necessarily. Oh, you still have your old EMR, or oh, you got your old DOS-based system. Yeah, you can bring that in, and we'll make it work with our Cerner or Epic or what have you. And then, well, you know, you only want to be open one day a week, etc. So lo and behold, when you have 5 docs, that's not even manageable, but you make it fit. But when you get up to 100, 200, 300 physicians, the thing bends under its own weight of inefficiency, right? So if you think about my trite model of a pyramid, if you've got no sound base there and you haven't built, you know, structure on top of that, you're going nowhere fast. And so ultimately, these folks ended up losing $400,000 a year per physician. And they said, hey, we've got some problems. I said, I think you do. So what we did is we went in, and it's the things that I mentioned, really, but in more detail, and I'll do them at disservice in limited time, but it's policies, procedures. It's physician expectation. They had no physician advisory committee. We built out an ad hoc committee out of the gate, interested physicians who wanted to contribute. And we got that deployed even just as an interim step because it showed the physicians, the other physicians in the network, that the health system was going to listen to input from docs. And so the short version is, and there are a lot of other steps, but that's the kind of nuts of it, nuts and bolts. But the short version is, within 18 months, they were $100,000 in the hole per doc, and then another 6 months later, they were break even on the employed model. So, and I think they're still doing significantly well in the black on both the hospital and break even on the network, which I think is about the best you can hope for, generally speaking. So that's kind of the crux of the thing.
Wonderful. Well, that's all the questions our participants do have for you, Jeff. Any final thoughts before we do officially close out here?
No, like I said, I just want to thank everyone for their time. I really appreciate it. Thanks for letting me present to you, and hopefully in the scheme of things, you're able to pull out a couple of things that got you wondering about kind of the nuts and bolts and the granular pieces that go into delivery. Again, it applies to health systems with employed models and private practices and everything in between. So thank you very much for your time.
All right. Well, thank you, Jeff, for an excellent presentation today, and thank you to all of our participants for joining this webinar.